Hello again, friends. We're going to talk here about interstitial lung disease. Now, interstitial lung disease makes up the bulk of the restrictive lung diseases. So you'll want to be aware of the various types of interstitial lung disease because if you have a restrictive pattern, these different things are going to make up your differential, and you should be aware of this. So let's go back to what obstructive versus restrictive is. And they both involve difficulty breathing, so they're both going to result in the symptom of dyspnea, which is difficulty breathing. Obstructive diseases is difficulty primarily with expiration. Patients with obstructive lung disease have difficulty fully emptying their lungs, but they don't have difficulty with their lung volumes. So they have difficulty fully emptying their lungs, and they have difficulty emptying their lungs at a fast enough rate. There is a degree of air trapping in their lungs, in their chest cavity, which does result in an increased total lung capacity. And obstructive disease, to one degree or another, involves a mechanical obstruction of the airways. So some examples of obstructive lung diseases include asthma and COPD. Those are the two big ones. Asthma being generally reversible by bronchodilator, COPD being the chronic, non-reversible form. Cystic fibrosis and bronchiectasis are also obstructive pattern lung diseases. On physical exam with obstructive diseases, you're going to hear wheezes and rales. Those aren't specific to obstructive diseases, but wheezes are very common with your asthma and COPD. And on chest x-ray, you'll see a flattened diaphragm, and that's relatively specific, but not pathognomonic for the obstructive lung diseases. And that flattened diaphragm is due to the fact that you have air trapping, and the diaphragm that forms the inferior border of the chest cavity is flattened from that excess air in the chest cavity. So restrictive diseases are going to be what we're talking about here. That's primarily difficulty with inspiration, but I mean, those are, when I say that, it's kind of a rough explanation. So patients with restrictive lung diseases have difficulty fully filling their lungs. So in general, patients with restrictive diseases, they have decreased lung volumes across the board. And oftentimes this is a result of diseased, stiffer lung parenchyma. So anything that can disease the lung parenchyma, the lung tissue itself, can result in a restrictive disease. And the diseased tissue acts as a physical impediment to expanding the lungs. It also acts as a physical impediment to oxygen delivery from the alveolus to the capillary. So this involves any of the interstitial lung diseases, and then also involves scoliosis, obesity, and respiratory muscle fatigue. Now the difference is that interstitial lung disease pertains to the lung parenchyma, whereas scoliosis, obesity, those pertain to, and respiratory muscle disease, those three things pertain to the chest cavity, something outside the lung tissue. So we need to be able to differentiate interstitial lung diseases from other things that can cause restriction in the filling of our lungs, because if it's something that's affecting our lungs, we need to approach it one way. If it's something that is affecting our physical ability to expand our chest cavity, then we approach it obviously in a different way. And lung resection can give you a false positive on your pulmonary function tests, and that's just because if you have lung resection, you only have half of your volumes, so it would appear with a lung resection, if you have only one half of your lung unit, then you're only going to have half of the volume. But it's a normal expected volume because you have only one lung as opposed to two. So lung resection can give you a false positive on your pulmonary function tests. On physical exam with restrictive disease, you're particularly going to hear those crackles. Decreased lung sounds is pretty common, especially in the interstitial lung diseases. Shallow breathing, and chest x-ray will often show a diseased parenchyma, which shows up as these ground glass infiltrates. Not all restrictive diseases have a chest x-ray that show diseased parenchyma, but a lot of them do. So let's just look at the what happens to the volumes. So with obstructive lung disease, really the only thing that's changing is your ability to expire air at an optimal rate. So with an obstructive lung disease like asthma or COPD, you're having difficulty expiring air at the rate that you should be able to. So the result of that is that your FEV1 is down because it takes longer to expire. It takes longer to expire X amount of volume. So you're going to your amount of expiratory volume in 1 second is going to be lower. Your FEF 2575 will be lower, and your FVC will be roughly the same. It's not, obstructive disease does not affect your capacity. So what the result of this is that your FEV1 to FVC ratio is going to go down. So the FEV1 is down, FVC stays roughly the same, and the result of that is a decreased ratio. Usually about 80% or less means an obstructive disease, but that can vary based on age. So for the most part, though, everything else in obstructive disease stays the same or increased. What we're mostly looking at when we're diagnosing obstructive disease is the FEV1 or the FVC to FEV1 to FVC ratio. If that is low, it's an obstructive disease. Now, on the other hand, with restrictive diseases, what we see is across the board decrease in lung volumes. So all of the volumes are decreased. Now you see some here in obstructive disease where the total lung capacity is up, the residual volume is up, the FRC is up. That's just due to the air trapping. So don't make too much of that. So FEV1 to FVC ratio in restrictive disease, it's usually normal, around 80%. However, it can be abnormally high. It can be over 100%. Why? Because the FVC is low. So the FVC being low, when we do our FEV1 to FVC ratio, because that denominator is low, that ratio is actually going to be higher. The FEV1 should not be affected. The rate at which we can expire, or inspire for that matter, should not be significantly affected by restrictive lung diseases. So the hallmark of restrictive lung diseases is the reduction in lung volumes across the board. Unlike in obstructive diseases, the FEV1 to FVC ratio will be normal, if not a little bit elevated, whereas in obstructive diseases, it's low. So this is just an example. You can see here your obstructive diseases, you've got a decrease in your rate of volume expiration, whereas in your restrictive diseases, you've got a decrease in your overall lung volumes. Okay, so let's look at this little spirometry module here. So this is an example of normal. So we're starting out with the residual volume. Here we've got flow. So this is inspiration here on the bottom. And then this is, as we go from left to right, this is an increased lung volume. So we start out with our residual volume that's fully expired. And as we're inspiring, these arrows just show the movement, we move to our total lung capacity. So this is normal here. Here's our TLC. And now as we're expiring, we go back to our residual volume. With restrictive disease, because all the volumes are usually a little less, we start out with a little less at our residual volume, moving to a little less at our total lung capacity, and then we move the same way back to our residual volume. So the way you can tell with this on this diagram is that our volumes are less, and the rate that you're going to reach is going to be a little less just because you have less air. But the most important thing is that your volumes are less. That's the hallmark of restrictive disease. Okay, so what are the restrictive lung diseases? They are those that pertain to the lung, the pulmonary diseases, and the non-pulmonary. So the non-pulmonary diseases that can result in a restrictive pattern are neurological. So those are things that basically are affecting the muscle, the nerve muscle unit. So if the muscles that help you breathe aren't working, that's going to cause a restrictive pattern because you're not going to be able to breathe in as much, and it's going to be harder for you to breathe out as well. So those can be things like Guillain-Barré syndrome and myasthenia gravis. Those are both neurologic symptoms or syndromes. Chest wall deformity is another thing that can mimic a restrictive lung disease. If you don't have the physical space inside your chest cavity, then that's going to decrease your expected lung volumes. And then obesity, that's just the result of having excess weight on your chest, and the result of that is going to be more difficulty breathing in and breathing out. So that's called Pickwickian syndrome, and it's generally not enough to cause any clinical symptoms, but just know that obesity can cause restrictive patterns on pulmonary function tests. Okay, so what are we going to talk about the most? We're going to talk about pulmonary causes of restrictive lung diseases. So these are the interstitial lung diseases, which make up the biggest category. Interstitial lung diseases are diseases that affect the interstitium. So they affect the lung parenchyma. They affect the transfer of oxygen from the alveolus to the capillary. With the other category of pulmonary restrictive lung diseases is acute respiratory distress syndrome. This is an acute syndrome, as noted in its name, and this happens generally in response to some kind of stressor, particularly an infection. So the interstitial lung diseases are going to be what we focus on for the rest of this talk. And the way I like to remember the interstitial lung diseases is by this mnemonic. Not necessarily the most professional mnemonic. I wouldn't go around the hospital saying this, but my philosophy with mnemonics is, I don't care how vulgar it is. If it works, it works. You're going to save lives with these things, so whatever helps you. So I use this. It's shit-faced, and these pretty much cover all of the interstitial lung diseases. So there's sarcoidosis, Histiocytosis X, Idiopathic Fibrosing Interstitial Pneumonia, which has just gotten a name update. It used to be called Idiopathic Pulmonary Fibrosis. For the USMLE, you should know both names, although I believe on the USMLE they should tell you IPF in addition to Idiopathic Fibrosing Interstitial Pneumonia, because this name change was so recent. Tuberculosis or tumors can cause restrictive patterns. Fungal infections, asbestosis or alveoloproteinosis, I misspelled that, collagen vascular diseases, environmental, occupational exposures, and drugs. Okay, so we're just going to give each of these a brief talk over. Oh, yeah. Okay, so IPF, idiopathic fibrosing interstitial pneumonia, is the #1 cause overall of the interstitial lung diseases. So what do we look at for making the diagnosis of an interstitial lung disease? We've got a pretty big differential. So we need to know medications, because drugs can be a cause. We need to know occupation, because if you're a coal worker or you work around silica or you work around asbestos or worked around asbestos, that can be a cause. Do you have a smoking history? That can increase your risk of different cancers. Are you an immigrant? That may mean you've been exposed to TB. Are you a healthcare worker? And so on and so forth. So a history is pretty important to narrowing down or focusing on a specific diagnosis that may be the most likely. Symptoms are going to be important as well. So exertional dyspnea, cough, shortness of breath, those are really non-specific symptoms as far as all of the interstitial lung diseases go. But other symptoms are important too, depending on the etiology. So if, for instance, the patient has sarcoidosis, you may see night sweats, fever. You may see some skin symptoms. You might see a sort of malar rash that looks like lupus. So that's going to be important. For tuberculosis, again here, fever, night sweats, former immigrant. fungal infection, if the patient was spelunking, if they're in the southwest, if they're in the Ohio River Valley, that can point towards fungal infection. A lot of these hints I'm giving you is for the USMLE, not so much for real life. Asbestosis, if the patient worked in construction, if they live in an older house. Collagen vascular disease, there's lots of them. So we're thinking things like rheumatoid arthritis, we're thinking things like Sjogren's syndrome and so forth. Environmental and occupational exposures. So again, those are things like if the patient's a coal miner, if the patient's exposed to silica dust, if the patient works with birds, and then drugs. On physical exam, again, it's going to be relatively nonspecific. So you can see why the history is going to be important, as well as those other symptoms that may come up. So inspiratory crackles, especially at the lung base, and then signs of chronic hypoxia like digital clubbing, but that's usually a little bit more further on if in the patient's disease. So primarily, you're just going to hear the inspiratory crackles at the lung base. That's really the only symptom, or the only physical sign you're going to get from the interstitial lung disease itself. The others are more specific to the actual cause. So you can have other physical signs, but they don't entail all of the interstitial lung diseases. What are some tests that you're going to need? Well, the pulmonary function test, as far as diagnosing restrictive lung disease, is the best initial diagnostic step. However, if you have enough things in your history that tell you that you may have a specific disease like sarcoidosis or like silicosis or coal workers' pneumonias or asbestosis, then in that case, a pulmonary function test may not be the best initial diagnostic step. But for diagnosing restrictive lung disease, then pulmonary function test is the best initial step. And the reason for that is because it shows you the reduced lung volumes, particularly in your total lung capacity. The diffusion length of carbon dioxide or carbon monoxide is important. This will always be reduced in any interstitial lung disease. And the nice thing about the DLCO is that it can help you tell whether a disease is, whether the restrictive disease is interstitial or due to ARDS, or if it's due to a non-pulmonary cause. Because if it's due to a non-pulmonary cause, then the diffusion across your lung should be normal, because the thing that's causing the restriction is from outside the lungs. And then your AA gradient would be elevated in any of the interstitial lung diseases. Again, that's going to be normal in patients with a non-pulmonary restrictive lung disease. As far as imaging, chest x-rays are going to play an important role in most of the diseases. It's normal in up to 10% of patients. Otherwise, things you see most often in the interstitial lung diseases are ground glass opacities, patchy to diffuse distribution. Obviously, there are differences. If you have sarcoidosis, you can see bilateral hilar lymphadenopathy, whereas if you see tuberculosis, you can see a mass, or with tumor, you can see a mass. So this isn't what I'm giving you is not fully what you're going to see in a patient with disease. This is just sort of overarching all of the interstitial lung diseases. A high-resolution CT is more accurate than a chest x-ray, but it doesn't necessarily mean that that's the best one to go to first. I like to go, if I see a patient that I think has a restrictive lung disease, has interstitial lung disease, and I don't see anything on chest x-ray, usually then I'll go to the high-resolution CT just to make sure. And the high-resolution CT is more accurate than the chest x-ray. It also gives you a particular finding that you see in advanced interstitial lung disease, and that's called honeycombing. As far as pathology goes, it is the most accurate test in diagnosis. The surgical lung biopsy is the number one most accurate test in diagnosis. And as a matter of fact, for for one subset of interstitial lung diseases is actually necessary to make the diagnosis. So any of the idiopathic interstitial pneumonias have to be diagnosed with a surgical lung biopsy. Transbronchial biopsies can be done as well, and then there's a procedure called bronchoalveolar lavage. For the most part, though, with the exception of idiopathic interstitial pneumonias, pathologies are sort of a secondary form of diagnosing. They've been mostly replaced with imaging and other modalities. Okay, so sarcoidosis is a multisystemic disorder. It stereotypically, but of course not always in real life, but you know how the USMLE likes to use stereotypes. It stereotypically affects a black female in her 20s, 30s, or 40s, but it can affect anybody. Sarcoidosis is idiopathic. It results in these non-caseating granulomas, which can occur really in any tissue, but it tends to occur in the lung, the skin, and the eyes most often. In the lungs, it results in fibrosis. In the skin, it results in a finding called lupus pernio, which is this purple induration in the lupus pattern. So the cheeks, below the nose, up the nose, and then it can cause these granulomas in the eyes, which cause uveitis. Patients with sarcoidosis need to be followed at least annually or semi-annually because they are at risk for bundle branch block if they get granulomas in the heart. So they need to have annual EKGs, they need to have annual ophthalmology exams. The classic finding for sarcoidosis when you diagnose it is bilateral hilar lymphadenopathy, and that will be noted on chest x-ray. The mainstay of therapy is prednisone. Histiocytosis X is rare, and when it does happen, it's in children, and even then, pulmonary manifestations is rare. So as you can probably guess, I'm not going to talk too much about this. All you really need to know for this is, actually, you probably really don't need to know a whole lot of anything for this. As far as medicine goes, this is mostly a pediatric disease. You can read about this on your own. I'm not going to spend too much time talking about this, but no, it's there. You're probably wondering why I talked about that now. Okay, idiopathic fibrosing interstitial pneumonia. So this is your diagnosis of exclusion. So once you have determined, okay, yes, I do believe that the patient has an interstitial lung disease, but you don't know which one it is, and you've eliminated all the other ones, then you go towards this one. And this is the #1 cause of interstitial lung disease. So remember, you're not going to go to histiocytosis X if you've ruled out all the other ones. You're going to go towards IFIP, and that's because this is the #1 cause of interstitial lung disease. And it was formerly known as interstitial pulmonary fibrosis or idiopathic pulmonary fibrosis. And like I said, it's your diagnosis of exclusion. So you want to make sure that you've looked for everything in every place before you venture a guess here. And the reason is because the only way you can diagnose IFIP is by a surgical biopsy. You require a surgical biopsy for formal diagnosis. And the reason is because there are multiple different subtypes of IFIP. And so in order to know exactly what IFIP the patient has, which is going to affect the patient's prognosis, you have to get a surgical biopsy. So surgical biopsy tends to be your last step. If you've got this patient that's got interstitial lung disease, but you have no idea what it is, and you've done everything, and you've looked for everything, surgical lung biopsy will help you make your formal diagnosis. But we try to avoid that because it's an invasive test. Classic findings on imaging, your chest x-ray shows diffuse pachyfibrosis, and high-resolution CT eventually shows honeycombing. Again, these are not specific findings to IFIP, so this is the diagnosis of exclusion. Unfortunately, IFIP has no proven therapy, and hence it has the worst prognosis. There is a form of idiopathic fibrosing interstitial pneumonia called BOOP, BOOP, which I believe stands for bronchiolitis obliterans organizing pneumonia, and that can be resultant of smoke exposure. So I'm not talking about secondhand smoke exposure or smoking. I'm talking about if you are in a house that was burning down and you happen to inhale a bunch of smoke over a long period of time and had any damage from that, that can be a factor that leads to future development of this particular interstitial, idiopathic fibrosing interstitial pneumonia. Okay. I wouldn't worry about differentiating the pathological subtypes for the USMLE. That's more of a step 1 question. Step 2 and 3, you should just know this is the diagnosis of exclusion and that it is a restrictive lung disease. And I would also know that it requires surgical lung biopsy for formal diagnosis. You cannot diagnose this without a surgical lung biopsy. Tuberculosis and tumors. So tuberculosis, classically on the USMLE, this is going to be an immigrant patient. People generally don't contract this in the United States. Immigrant patient or maybe a healthcare worker. Chronic cough, fever, night sweats, weight loss. Those are all signs of tuberculosis. Those are going to be your additional signs in addition to your dyspnea and your rales and wheezing that you see in all the other diseases. The initial test is the tuberculin skin test. If you believe that the patient may have tuberculosis and you administer the skin test, if it comes back as positive, you're going to get a chest x-ray. If the chest x-ray comes back as positive, then you're going to get a sputum sample. If the sputum sample comes back as positive, then the patient has active tuberculosis, and you're going to treat them with multi-drug therapy. If the patient has a negative sputum sample, but they still have the cavitation on the chest x-ray, then they are considered to have latent tuberculosis, and then you're going to treat them with 9 months of isoniazid. I talk about this more at length in the infectious disease section. As far as tumors, classically tumors show up in the long-term smoker, 80 to 90%. Chest x-ray will show the lesion. Biopsy is going to be required for diagnosis and staging. What kind of biopsy you do depends on where the tumor appears on the chest x-ray. So some need to be an open biopsy. Others can be just biopsy via bronchoscopy. Fungal infections, I talk about this more in the infectious disease section, but that can be from aspergillosis, blastomycosis, histoplasmosis, coccidioidomycosis. These you would, of course, suspect when the disease comes on acutely. If the patient has a history of being in caves, playing in the mud, recent travel to the southwest, if the patient is immunocompromised, and so forth. Asbestosis is a prominent occupational disease caused by exposure to asbestos. I should say asbestos there. Asbestos is a flame retardant and was used in building and industrial materials. It was used from the start of the Industrial Revolution pretty much onwards until the 1970s, and it still exists in some buildings. And so, and also because asbestos is a pneumoconiasis, it can take up to 30 years for somebody to develop the symptoms of asbestosis, even if they were exposed to it. So just because somebody's not working around asbestos now doesn't mean they can't develop asbestosis. If they were exposed to it 30 years ago, 40 years ago, they could still develop asbestosis. So what asbestos does is it causes pulmonary fibrosis. It also causes an increased risk of all lung cancers, including mesothelioma, which is tightly linked to asbestos exposure. Now, please remember that asbestos, the number one cancer that it causes is non-small cell lung cancer. And I know that it's very easy to assume, oh, the number one cancer with asbestos is mesothelioma. Well, yes, there is mesothelioma with asbestos, but that's just the cancer that's most tightly linked to asbestos exposure. So if you have mesothelioma it's almost certain that you were exposed to asbestos. However, people that are exposed to asbestos, most of them, if they develop cancer, they get non-small cell lung cancer. I also want to emphasize here, and I talk about asbestos in an individual section, but I also want to emphasize here that if you are a smoker, while you are exposed to mesothelioma, it dramatically increases your risk of cancer up to 75 times. And the reason for that is because anybody who smokes, their ciliary clearance mechanism is hampered. And so when you breathe in those asbestos fibers, they're more likely to stay inside of your lungs for good. And on imaging, there are a lot of different things that you can see in asbestosis. You can see pleural thickening, you see reticulonodular infiltrates, and characteristically in asbestosis, you see these little calcifications on the top of the diaphragm. Collagen vascular disease can also result in restrictive lung disease, and this is just a manifestation of the autoimmune disease. Most often, it's associated with lupus, rheumatoid arthritis, Sjogren's syndrome, dermatomyositis and polymyositis, and Churg-Strauss syndrome. Remember, in Churg-Strauss syndrome, you also have asthma. So, if you get a restrictive disease with that, you get the double whammy because you've got an obstructive and a restrictive disease. The key for diagnosing restrictive disease secondary to collagen vascular disease is the existence of symptoms related to the collagen vascular disease. Most of these patients are going to have a previous diagnosis. So restrictive lung disease is not a presenting feature of any of these diseases, but it is something that they can develop down the road. And I talk about all of these diseases in greater detail in the rheumatology section. Environmental and occupational causes include smoke inhalation, gastric aspiration, the pneumoconiases, which are coal workers' pneumoconiasis, silicosis, and asbestosis, and then hypersensitivity pneumonitis, which can be either acute or chronic. The most common are farmer's lung and bird fancier's lung. The difference between pneumoconiases and hypersensitivity pneumonitis is that the pneumoconiases are an exposure to non-organic dust matter, whereas the hypersensitivity pneumonias are exposure to organic matter. And what happens with the hypersensitivity pneumonias, as the name says, is it elicits a hypersensitivity reaction, and so you get a more robust acute inflammation. Whereas with the pneumoconioses, it's a chronic, long-term sort of deal. So I talk about these in greater detail in their own section as well. And then the drugs that can cause restrictive lung disease. I kind of put the most common ones on here, but there are really a lot that can theoretically cause restrictive disease. Bleomycin is the most common one associated with lung disease because it's used in chemotherapy, so it's not used very often, but when it is used, it causes pulmonary fibrosis very frequently. Busulfan is another one. Amiodarone, which is an antiarrhythmic, can cause lung disease. That's also relatively common with amiodarone usage. Nitrofurantoin, which is an antibiotic, that doesn't happen so much with nitrofurantoin, but it is possible. And then methotrexate, which is an immune modulator given for a lot of the autoimmune diseases. Radiation therapy can also cause pulmonary fibrosis as well.